and surprises. بنشوف الوايت كاتاراكت في الأطفال in different pathologies. بنشوفه أحيانا كcongenital total وده ممكن يكون as a progression of zonular cataract. بنشوفه كممبرنس لما يحصل absorption لللينس وده بيحصل في بعض حالات الانفكتيف or non-infective etiology. بنشوفه في البوستيريور لينتيكونس لو progressed into full thickness defect وحصل hydration of the lens فبيجي لنا الطفل بوايت كاتاراكت واحيانا ميزد باثولوجي وما بنشوفوش غير انترا اوبراتيف. بيجي لنا وايت كاتاراكت in association with other ocular or systemic pathology زي axenfeld, aniridia, uveitis, primary congenital glaucoma, بعض حالات الار او بي لو developed cataract. طبعا التروماتيك كاتاراكت والبنتريتنج تروما والسيناريو المعروف وايت كاتاراكت with opened anterior capsule and then smatter in the anterior chamber او تنتهي بريزوربشن كاتاراكت. في البلانت تروما ممكن نقابل فيها فايبروتيك بليكس pre-operative open posterior capsule or lens subluxation. طبعا as usual pre-operative preparation لكل البيدياتريك cataract ولكن هنا we have to stress على ان الالتراساوند needed to be done by an expert يعني هيفيدنا كتير في حالات الوايت cataract. UPM is helpful او نقدر نقول mandatory في بعض الحالات بالذات لو كان البيوبل not dilated. You have to prepare a surgical plan and be ready to change the plan during the surgery. طبعا prepare all facilities and tools, micro instruments, هيمون, IOL. عن يعني كل حالات الوايت كاتاراكت حتى لو متأكدين ان الانتيريور والبوستيريور كابسول intact will be repaired 3-piece IOL for the surgery. Apart from the usual standard surgical steps for pediatric cataract surgery, certain precautions in these cases. You have to find for capsulorhexis. You may deal with capsular fibrosis and plaques. Pre-operative open posterior capsule is very common in these cases. You may face unusual surprises or hidden pathology. In this case, as usual, there is a fluidy content of the lens. Once incision by cystotome, there is a fluid coming out of the lens. So stop, try to aspirate some lens matter, inject heavy viscoelastic, then continue the capsulorhexis as usual. In some cases, after syneculitis, we may face opened anterior capsule in white cataract. In this case, opened anterior capsule is of type 2, which is fibrosed, which is more safe أثناء السيرجري. أبقى مطمنة إن هو it will not extend. So open it with scissor and complete with micro forceps as usual. And this is after posterior capsulorhexis, anterior vitrectomy and in the bag IOL implantation. أحيانا البليك in the anterior capsule تبقى more dense ما بتتفتحش لا بالسيستوتوم ولا بالسيزر. You have to do step incision at the edge of the plaque by MPR, then continue the removal of the plaque by the micro scissor. So to deal with capsular fibrosis or plaques سواء anterior or posterior أحيانا تبقى very loosely adherent وبالتالي you can peel it easily. أحيانا بنحتاج بعض الانسترومنتس زي مايكرو سيزر أو MPR أو to grasp the plaque with micro forceps and complete the rhexis with micro scissor. أحيانا بنحتاج الفيتريكتومي. It is very dense. We have to need to use a vitrectomy by slow cut rate and high infusion rate. Sometimes the capsular plaque زي الحالة دي بعد syneculitis عامل stretching and striation of the anterior capsule. So we may do the anterior capsulorhexis in a staged manner. To start with the usual, using the micro forceps and microrhexis, micro scissor, to overcome the striation and the fibrosed part. Then we may complete the rhexis or reform it into circular pattern by vitrectomy. In the same case, the posterior capsule also has a posterior plaque. So a step incision in the posterior capsule and completed with micro scissor. Inside the lens, we have to remove some parts of the fibrosis to prevent capsular phimosis. It is very thick and not cut by vitrectomy, so we have to do some step incisions in the fibrosed part to facilitate the job of the vitrectomy. Again, another case with 4 months with congenital cataract, it has a posterior plaque. In this case, we used a step incision, then completed it directly with vitrectomy. But take care in using the vitrectomy to do the posterior capsulorhexis, not to extend the posterior capsulorhexis larger than usual. We have to remove all parts of the fibrosis to prevent the capsular phimosis. Sometimes we face pre-operatively opened capsule. كلينيكالي بيبان قبل العمليه ان هو ممكن يكون ديب انتيو تشامبر، الانتيو كبسول بيبقى فلات او some sort of concave. انترا اوبراتيف هيبان الاوبننج اوف ذا بوستيريور كبسول، واشهر شيب انه يبان في شكل سبندل شيب في بالذات حالات اللينتيكونا سوري. احيانا بنشوف الفيش تيل ساين. الفيش تيل ساين بيبقى فيه لينس ماتر ان ذا anterior vitreous serosa opening، وبالذات بتزيد مع الموفمنت اوف ذا اي. Two types of opened capsule ممكن نواجههم. Type 1 وده not safe قوي لان ما بيبقاش fibrotic age وبالتالي ده liable to extend during surgery، او Type 2 ده fibrotic وده more safe to deal with it اثناء السيرجري. الجولدن رولز المعروفه لو انا شاكه ان في بري اوبراتيف opened posterior capsule، try to open side ports only ونأجل المين tunnel لنهايه السيرجري علشان to form or provide tighter anterior chamber. Anterior chamber must to be maintained all over the surgery. Use heavy viscoelastic. Perform anterior capsulorhexis through the side port by microforceps. Hydrodissection is avoided, and try to convert the opening into rhexis. As in this case, it is a blunt trauma. There is a white cataract, a swollen lens. After complete anterior rhexis, during IA, we found there is a hidden tear in the posterior capsule. Stop. Inject viscoelastic before removal of the irrigation. This is the opened anterior capsule. Then try to convert it into posterior capsulorhexis using scissor and microforceps. So now we have a complete anterior and posterior capsulorhexis, and complete the surgery as usual by triamcinolone assisted vitrectomy and 3-piece IOL implantation with optic capture. This case, there was a congenital child with congenital cataract 2 months. There is a pre-operative opening in the posterior capsule. You can enter through the opening by the vitrectomy probe and clear the lens matter before fashioning of the posterior rhexis by vitrectomy. Here we completed the rhexis by vitrectomy. In some cases الفايبروزس والثيكنينج مش بس في الانتيريور والبوستيريور كابسول، ده كمان inside the lens. الطفله دي كانت 5 سنين with short stature, hypoparathyroid disorder وهايبركالسيميا. developed white cataract سريعا جدا على حسب الهيستوري of parents. الانتيريور كابسول مش just a plaque, it is calcified. في calcifications على الباك surface of the anterior capsule. كمان during the IA the lens matter is very thick and calcified and very difficult in aspiration. This is after posterior capsulorhexis and 3-piece IOL in the sulcus with optic capture. It's the case of uveitic cataract inside the lens after capsulorhexis and aspiration. There is a layers of fibrosis also inside the lens. We have to deal with it with cutting of the fibrotic plaques and the removal of it either with micro scissors or by vitrectomy probe. بعض الأحيان بيبقى فيه hidden pathology في الوايت كاتاراكت، so don't depend على الهيستوري. زي الطفل ده جالنا بهيستوري صريحة لتروما. During surgery, after anterior capsulorhexis aspiration of lens matter, we found that there is a persistent fetal vasculature with hyaloid artery. So we started to deal with it as persistent fetal vasculature. Opening of the posterior capsule during complete capsulorhexis. Sorry, 1 minute. So to conclude, we have a special consideration post-operative for longer periods and more aggressive follow-up and treatment. To conclude, pediatric white cataract cases are actually challenging with surprises. You have to do good pre-operative examination, meticulous ultrasound, UPM not just helpful, it is mandatory in some cases. Be ready with all tools and facilities to unusual scenarios, and every case has its own plan. وخلينا مستعدين ان احنا نغير البلان دي during surgery to reach the optimum outcome. Thank you.